Okay, right. Thank you very much. Thank you, Dr. Said. Good evening, Sham Bakhair, ladies and gentlemen. Thank you very much for joining back on another evening of Sunday. This time we have EUS on EUS anatomy of heritability tree and the possible interventions that we can do. And to talk on that, we have Sandeep Lakhtakia. His name is well known in the endoscopic ultrasound circuit. He's a director of the endoscopy and EUS in the AIG hospitals, Hyderabad, and we all know the contributions of AIG Hospital Hyderabad in the field of science, in the field of endoscopy, and similarly in the field of endoscopic ultrasound. He's been very kind. He has spared his Sunday evening for us. I know there are lots of people who are joining us on Facebook, but then there are lots of people who are there on the Zoom as well. I'm thankful once again to Sandeep, and Sandeep, it's all yours. Please start.
Thank you, Professor Gas, and my dear friends uh, in Pakistan. So, as Professor Gas said, I'll be speaking on EOS anatomy of hepatobiliary tree, which was the topic allotted to me. But I thought I'll add the word interventions to make it more interesting and for people to be glued in to whatever we speak and discuss later on. So the agenda of my talk would be to cover the biliary tree starting from bottoms up, that is from ampulla to the bile duct, cystic duct, gallbladder, common hepatic duct, and intrahepatic ducts, and also the liver, the left and the right lobe, how well we see, and what are the vessels and other things, structures that we are able to see. So, so the left part of the screen looks only the theoretical part, but the right part is the real game. And EOS has made real strides in biliary and hepatic interventions, and it's a very exciting field. It's competing and almost kind of in some places it's overtaken percutaneous interventions for the biliary and the hepatic related interventions, and it's also competing with ERCP. Let's move forward. So I'm told there are beginners also in this forum, and that's why I said I will just make few videos which will make you understand how radial and EUS differ from each other. There's a pretty common slide which I show, but it's a very good illustration of, on the left panel you can see the radial EUS, how it moves and how the cross-sectional image at different places comes on the screen, and then you can make an identification of what's going on. On the on the right panel is the linear EUS, which also moves with an endoscopic view, but it has the added advantage of doing an intervention. And that's the basic difference between the radial and the linear. Radial is diagnostics, gives 360-degree view. As you can see on this, it gives a cross-sectional image, which is O-shaped. Ultrasound image is seen at the level of the scope tip. You change the image on the screen by push and pull. The image quality is generally very good, but intervention cannot be done by radial. Whereas on the left is a linear EUS, you get a sagittal or a D-shaped image, unlike O in the radial, where ultrasound also can see beyond the tip of the scope, and that's little important. We can discuss that later. And to change from one view to other, you torque your scope. So you go either clockwise or anti-clockwise. Just few degrees movement will give you a different image altogether. Image quality is quite good, and also you can intervene, as we said earlier. So this is how the images look like. On the left is a linear EUS. This is a large pseudocyst where you can puncture with a needle and then try to drain it off. And the right panel is a radial EUS, because you get image all around. It's a 360-degree image. And if you do an FNA, the needle goes in this direction. So you can see always it's in the view of the ultrasound. Whereas if you try to do FNA from a radial, you'll only get a cross section of the needle, and we'll not know how deep you have gone, and there is a risk of complications which can occur. So coming back to the biliary tree now. So we'll start from the biliary tree and ascend up into the bile duct and towards the liver. So we see with the radial EUS, if you position the scope in the first part, we can see the bile duct along with portal vein and the pancreatic duct. It's called stack sign. And then as we go a little down, we come nearer to the papilla. So we see the ampullary stones and tumors. It's called a snake eye appearance because sometimes you see just the tip of the PD and the CBD. Along with that, we also see a large part of the pancreatic head, along with superior mesenteric vein and artery, a very important landmark for the point of view of staging any pancreatic head tumors. And third part of duodenum, it's beyond the biliary tree, but we see the uncinate process, the aorta, and the IVC. So mainly the CBD by radial is assessed from first and the second part. So this is the image. If the scope position is like this in the first part of the duodenum, so you get a very good view of little push and pull. You will get the bile duct, and sometimes you can see the bile duct in entire length from top to bottom. You see the gallbladder very close quarters, often from the D1, but sometimes also from the gastric antrum, because gallbladder is a very flexible organ which can float around in different parts. Pancreatic head is nicely seen, PD, portal vein, superior mesenteric vein, the confluence of superior mesenteric vein and the SMV forming the portal vein, and hepatic artery and GDS. So a lot of vital structures are seen from the first part itself. And as you generally slip down to the second part, you can see other structures. So if you see this real-time image, this is the portal vein here, this is a PD there, this is a bile duct, which is seen only in the upper part in this frame with some filling defects inside. And there's a diverticulum in the duodenum. I'll show this video of the same patient later on so that then you will understand how useful it is. This is a still image. And so this is how the image would look like. The superior mesentery comes from bottom, splenic vein comes from the right of the screen, left of the screen, and both join together to form the portal vein, which ascends up into the liver. And then from the same frame, you can see the common bile duct very close to the transducer. And if the transducer is pressing on the duodenum, sometimes we may miss it. And that's a small trick there, that you have to move away from the duodenum and try to fill that gap between the transducer and the duodenal wall with water. If you're not able to see the duodenum, if you're not able to see the bile duct in the first go. And below the common bile duct is the pancreatic duct. So all three ducts, two ducts and the portal vein stacked together is called a stack sign. Let me show you a video on the right side, almost similar to what you on the left, is a bile duct stone. I'm sure anybody who is doing a little bit of ultrasound would know that this is a bile duct stone. This is one of the favorite images of mine quite some time back, more than 15 years ago, which I had grabbed. So let me show you some interesting cases. That will probably interest the audience. So this is so we see the papilla very nicely. If somebody tells me that in entire hepatobiliary system, which is the best organ to be seen by the EUS, I would say papilla, which no other investigations currently can do as well as EUS. And the reason I say it is you can see the image yourself. This is an ampulla of weight or a papilla. It's in a slow motion movie. With the peristalsis, the papilla expands and contracts. And you can see the CBD just taking off here and the PD is going little down. So any tiny tumor or a stone or any pathology in the bile in the ampulla of Vater, if you're suspecting, I think EUS should be done first. I repeat it again. If you're suspecting any pathology in and around the ampulla of Vater, do EUS first, not ERCP. You can have a CT scan and MRI and all those things. Those are the non-invasive investigations. When you come to invasive investigations, before an ERCP, my request to all the audience in this fora is that please do an EUS first. The reason I'm saying that if you happen to have a very tiny tumor and the bile duct is dilated above, patient has come with jaundice and you do an ERCP, do a sphincterotomy, place a stent, and you feel that you have done a great job. The problem happens is that that small tumor now gets missed out. It's hidden behind the stent and stent causes artifacts. You do an EUS later with a stent inside, it's quite likely that the tumor can be missed. So tumor which was operable to start off with has now become hidden and the delay in diagnosis happens. And sometimes these tumors now present later after months because stent is draining the system, patient is happy, gone away. And he comes back with obvious ampullary tumor which has now metastasized. So this is one take home message, if I can say now itself in the beginning of this talk. is always any ampullary pathology, please do EUS first. Moving forward, let me show you another case. This is a 75-year-old man who had dilated CBD with normal LFT. This was incidentally found on in routine investigation, as often happens. You can see the bile duct is quite dilated. This is the gallbladder. But the most interesting thing is you see here. Before I give an answer, I want guesses from people. Uh, you can put it on the chat box also. That's a pancreas behind a normal pancreatic duct. And Gyas and Saad would have, I'm sure, already diagnosed it. This is a large periampular diverticulum. So the trick over here is that you put water in the duodenum. If you're not able to find what's happening in the lower part of the CBD, it's not looking like a classical tumor or it's not a stone. Let me run this video quickly once again. Look, what happens is that I'm putting water in the duodenal lumen here, and then the water comes inside. You can see some movement, Brownian movement of the fluid going inside the diverticulum and coming out. So putting the water in duodenum is a second trick. If you're doubting your pathology or you're not able to see clearly, sometimes air artifacts intervene because air can be trapped in this diverticulum. That's when putting the water would help you a lot. So this is a duodenal diverticulum presenting as obstruction or compression of the lower CBD. A common scenario of a patient presenting with acute biliary pancreatitis. They have acute pancreatitis with abnormal liver functions. Gallstones are there, and you are now looking whether stones is there in the bile duct or not. And EUS again becomes a first or a primary modality of investigations in an invasive way. And you see a stone here at the papilla soon, and that's the stone, which actually looks like a shadow. So whenever there's a shadow behind this crescent, it's a stone there. And then you have the bile duct, which is full of stones, multiple stones. So the top ones are quite easy to see, but the one at the ampulla becomes a little difficult. You can also see the gallbladder stones with the thickened gallbladder here. So this is a patient with gallstones and CBD stones with mild biliary pancreatitis, soon underwent an ERCP and in the same session. And that's another advantage, that if you're sedating your patient while doing EUS and it's a facility of fluoroscopy is present in the same room, which most centers have, I think it's wise to do the ERCP in the same session. A very interesting scenario. This is a patient who has a post-cholecystectomy bile duct stricture. And it's a short stricture. And this patient underwent an ERCP first because he had jaundice and the index of suspicion was stone was there. And as you see, there's a stent there. And this ERCP is done after the stenting. And you can see this is a cystic duct with a stone inside it. I'll just play it again. So bile duct, which is dilated from top to bottom, but in between is little compression because of the stone in the cystic duct. So this is a Mirizi's syndrome, which was causing the obstruction, and brush cytology and biopsy from that stricture was negative. Moving forwards to linear EUS, and that's how the linear EUS scopes look like. This is the field of view of the linear EUS. It's a D-form, D-shaped, and any pathology which comes in front within this field of view, we can always FNA like this. So when we come to hepatobiliary investigations with the linear EUS, you can see the bile duct or the liver from the stomach. And depending on where the position of the scope tip is, you can see different parts of this hepatobiliary tree. So whether it's in the stomach or D1 or D2 or further down, we evaluate, because pancreas also comes in close quarters. So we cannot actually say that I'm not looking at pancreas. They're all part and parcel of the same system. So ampulla is seen very well also with a linear EUS scope. So both scopes, radial and linear, have the advantage that for the ampulla veta, you can choose whichever you're comfortable with. And let me show you some examples of an ampullary lesion pathology. So my personal preference is to fill the duodenum with a lot of water. As you can see it here, that moves the air away and gives a very good acoustic coupling. And you see there's a small tumor here. This is what I was meaning in the beginning. A very tiny tumor, maybe less than centimeter in size, and above that is a CBD dilated, and the PD is just prominent here. And this tumor is very easily amenable to an Whipple's procedure. This was an T1 adenocarcinoma. Some interesting things which I'd like to show here when we're looking at the ampulla is you see this is a projecting cystic lesion in the duodenum. Any guesses? Oh, the answer is there on top actually. It's a colodococele. You can see it's nicely projecting and the PD is just below it. And even the upper CBD is dilated. And the treatment over here is just de-roofing the papilla. Let me show you on the right of the panel. I have not given answer. I would like the audience to be giving me the. So that's another patient on the right side, is a different patient who has dilated CBD. I would let the video play on its own. This is a duodenum which is filled with water. That's the bile duct. And it's quite dilated as I move away from it, as you can see it now. So CBD is a compressible structure. If you press it, it becomes a short diameter, and as you move away, it comes back to its original diameter. You also see this is the cystic duct, which has a very low insertion quite near to the papilla, and this is a distended gallbladder. So I'm trying to see the terminal most part of the bile duct where it opens from the ampulla of Vater. Is there a pathology there? And I failed to see anything there. This is the dilated CBD, the cystic duct opening, but this is almost very close to the papilla and there's hardly any lesion here. And this is actually a colodocal cyst. And colodocal cyst, we all know, has a risk of malignancy in future if it's not operated. And that's another utility of EUS, that you can pick up early tumors if it happens to occur in a colodocal cyst. Moving forward, it's very good for the CBD stones as well. It depends on how comfortable you are with a linear scope. You can see multiple stones stacked in the CBD. You can see both in the long position of the linear EUS scope as well as the short position. Another example of usefulness of linear EUS, this is the pancreatic head mass, which is the distal CBD and the PD are very close to each other and they are normal, but as they merge with the mass, then there will be stricture and upstream PD and the CBD both will dilate up. So just to keep in perspective that you can see the ampullary pathology, the lower CBD pathology, entire CBD pathology, or anything which is compressing the bile duct or infiltrating the bile duct, it can be seen by EUS. So this is a pancreatic head cancer. Ascending up in the bile duct, now looking at the hilum area, it's not as good as the lower and the mid CBD, but nevertheless, it gives an answer because current technologies for the hilum are all, I would say, suboptimal. They haven't reached the perfection as yet. You can see something on MRCP, but you need to take a biopsy because cholangiocarcinoma or the gallbladder cancer are the commonest things here, which mimic any benign biliary strictures in the hilum. And differentiating the two, you need a tissue. And which way to move forward is the way many technologies are competing here. We have the ERCP with brush and biopsy, which have the modest yield. And then we have cholangioscopy, spyglass, and other cholangioscopes, which are useful but have the risk of causing cholangitis in a hilar stricture, which is beyond type 1, that is type 2, type 3, if you infect undrained systems. EUS gives a view of that area, but doing an FNA in a patient who is potentially resectable also carries a challenge. So EUS tells us that stricture is there or not, and whether that stricture, if it has a mass, you can FNA it, but if it's only lymph nodes, you can do that. Or if it looks to be potentially advanced stage, which was not picked up by the other imaging, then EUS FNA can be done. As you can see it here, I'll slow down intermittently this video, this fast forward. So this is the caudate lobe. IVC was coming here. This is the dilated intrahepatic duct. What I was trying to show is that there's a tumor here in the bile duct. Sorry, this here. That was a node. This is a dilated common hepatic duct, and it merges with a small thickened area, which was actually a CBD. I'm sorry, this is not a perfect video, but this is a lymph node here. So this tells us that this is inoperable, and FNA from this showed cholangiocarcinoma. So we need not target the primary the lesion, but the secondary or the surrogate markers of the tumor appear with EUS, and they can be targeted, and that gives an answer. Let me show you another example of a patient who had come with a dilated CBD with a obstructive jaundice and a mass-like thing inside. Whether this is sludge ball or it is something else, you see when you play Doppler and you see Doppler signals continuously and persistent in that area, that suggests this is a tumor tissue and not a sludge. This is a hugely dilated CBD, hugely dilated gallbladder. It is a polypoidal mass projecting in the CBD. So this was a variant of a cholangiocarcinoma, which are much rarer compared to the fibrostenotic type of malignancies which involve the bile duct. I'm showing all varieties of it. On the look of it, it looks to be resectable. The portal vein behind is not invaded at all. There's no lymph node, and so was confirmed on other imaging, and he underwent a successful surgery. You can also see the interesting part is you can actually see the bile duct from the stomach. If you happen to have a duodenal obstruction for any reason, be it benign or malignant, and you want to interrogate the bile duct, then stomach can be a way to look at it. Although ideal would be duodenum, but let me show it. So sorry. So this is a patient who had EUS for some other reason, but we found a lot of interesting things. Let me go back again and show frame by frame. Okay. Sorry. So there is actually the minor and the major duct of the pancreas, which could be seen here. Here it comes. It comes as look, this one. And behind that is a CBD, which is a normal CBD. So this was not intended for this procedure, but we happened to grab a very nice images. As you can see it here, the CBD is just behind the main pancreatic duct, somewhere here. And especially if it's dilated, here it was. So if it's dilated, it would seem better. For seeing the bile duct in entirety, it is possible to do from the stomach, provided you fill duodenum with water. And there are no air artifacts there. Moving to gallbladder, ascending further, that gallbladder stones can be easily picked, as we can seen it earlier. And this is a patient who had a microlithiasis, a recurrent pancreatitis with tiny specks inside. And on the right side, you see a different pathology. This is a gallbladder polypoid lesion, and contrast enhanced EUS showed that this polyp was enhancing on injection of contrast. It's lightening up here, and that excludes a possibility of a sludge, because sludge is a very common sludge balls we can see in the gallbladder quite commonly, and they are differential diagnosis of a polypoidal lesions. And any polyp which is more than 10 millimeter or it's increasing in size, I think requires a surgical removal of the gallbladder. And this is where contrast enhancement would help us. So technologies in addition to routine EUS would help us. So let's move to the intervention part of the hepatobiliary segment. So for biliary interventions, EUS helps both for EUS guided biliary access as well as biliary drainage. There are two different things. Biliary access is just entering the bile duct, and then you can switch over if you want to do a roundover procedures to an ERCP scope, provided the Guidewire has come out of the papilla, or you can continue to do the entire procedure through the EUS. And that's what the difference means. So access with or without drainage. So when we say of biliary access, this is a very common diagram which I use, which was published in Spanish journal from a friend. So bile duct can be entered from the stomach, the left hepatic duct, and then you can descend down from the left hepatic duct into the common hepatic, bile duct, and the ampulla of Vater with the guide wire. Other way to enter the biliary system is, if it's dilated in the lowermost part, is to enter from the duodenum. So you have two access routes, the left hepatic duct and the common bile duct, provided the common bile duct is dilated, whereas left hepatic duct is accessible in all scenarios. So the intrahepatic approach is from the proximal stomach, whereas the extrahepatic approach is from the duodenum bulb or D1 D2 junction. Having said that, there are two access routes. Now then there are three permutations possible of the drainage routes. What I mean by that is, if you have entered from the left hepatic duct and the guide wire happens to negotiate all the way across the papilla, you can either place a stent from stomach and leave it into the left hepatic duct, or you can go across the stricture wherever it's located and place a stent antegradely across the papilla. Or third option is, you pass the guide wire and switch your scope to a duodenoscope and then do the ERCP with the roundover procedure. So we have retrograde transpapillary approach, antegrade transpapillary approach, and a transmural approach. So all three approaches are possible by both the routes of entry. Although transduodenal antegrade stent is very rarely used, and so is even the guide wire often always goes to the hepatic hilum. So doing a antegrade or a rendezvous from the duodenum side is technically more challenging. But theoretically, all six options are possible, especially in malignant biliary obstructions, because there we place a metal stent, whereas in a benign biliary obstruction, these options are not available to us because we don't want to place a metal stent in a benign diseases. So how do we tackle that? We'll discuss further in this talk. So when do we use EOS guided biliary drainage? And the common indications are failed biliary cannulation, tumor invasion of the papilla or the duodenum, stone which is tightly obstructing the stone and allowing us not to go inside the bile duct from the papillary route, or is a very tight stricture, or there are anatomical variations or a periampulate diverticulum. Also, situations can be where the papilla is not accessible at all. In the previous slide, the papilla was accessible, but now if it's not accessible because of duodenal narrowing, either because of benign or malignant underlying conditions, or there's a surgery in the past which has prevented us to reach, say, Roux-en-Y system is there, or tumor invasion. So in this situation, you can do a direct one-step antegrade stent placement with upstream or downstream drainage. I can discuss this later on, what I mean over here. So on the left is the intrahepatic approach. This is the left lobe of the liver, a left hepatic duct, and your scope is stationed in the proximal stomach. You can easily go through the parenchyma and enter this duct and then do a cholangiogram and pass a guide wire and do whatever you want. This is a dilated bile duct. The scope is in a long position. That's the needle, and that's the guide wire which is going towards the hilar side. So in the intrahepatic approach, the puncture is made from the stomach, and then an extrahepatic approach, the puncture is made from the duodenum, the contrast filled, and the guide wire is negotiated across the papilla. And then in this situation, and thus you can actually do a roundable procedure. So what are the interventions possible? Biliary access, you can do a roundable procedure for a benign disease, for a biliary access and drainage is both required. Then you can do colodocoduodenostomy with a metal stent, Hepatical Gastroscopy again with a metal stent, and an antegrade stent, metal stents for a malignant disease, and occasionally plastic stent for a benign disease. The last part, antegrade stent, if it's a benign disease, that usually the intrahepatic ducts are not so dilated. When I say benign disease, it may be the benign biliary stricture or a stone disease. In stone disease, IHBRs are not so much dilated, whereas a tight strictures benign physiology can cause sometimes, and then you can use this option. So how do we decide which way to go for EOS guided biliary drainage? It depends on the anatomy of that patient, if it's a normal anatomy or an altered anatomy. The second important aspect that we look at is the papilla present or absent, and is it accessible or not. The third important thing that we look into is what is the likely indication of this patient. If it's proven malignancy, then you can be more liberal in placing a metal stent whichever way you enter. But benign disease, your options get limited there. And where is the site of the block located, especially if it's a malignant disease? And based on all these four parameters, which are in orange, you decide how to proceed further. So if it's a papilla is accessible, ERCP is our way to drain the biliary tree. But if it fails, we do EUS guided roundover procedure in benign disease, or we can do a EUS guided CDS, that is colodocoduodenostomy for a distal obstruction, or a EUS guided hepatogastrostomy when the papilla is not accessible or not possible, then we can do for the hilar block. And if everything fails, we can still consider PTBD. The conventional approach has been to do PTBD first and EUS CDS and HGS later. But now there's a competition going between EUS and the percutaneous intervention guy, and depending on who is strong and who has got the patient and who has the patience, I think uh, the debate going on there. So a few slides on the steps that we do for EUS guided biliary access and drainage. You access a dilated bile duct with a 19 gauge needle. Use the hollow needle and not one with a stylet. And this hollow needle is loaded with a dilute contrast. So that's the first trick. Never go with a fresh needle. Take out the stylet before introducing inside the patient the needle. So once you enter the bile duct, obtain a cholangiogram, then pass a guide wire into the bile duct under fluoroscopy. So good fluoroscopy is mandatory. And if you're trying to do an HGS, that is hepatogastrostomy, place the patient in either prone or supine position. Whereas for a colodocoduodenostomy, any position is okay. And the further steps are based on how the guide wire manipulation happens. So scenario one happens when the guide wire is advanced antegrade across the biliary stricture and the papilla into the duodenum. So whichever route you have entered, via duodenum or the liver, you can go across. And if you have wire across the duodenum, then you have lucky to have all possible scenarios with you. You can do a transpapillary guide wire drainage by retrograde route or antegrade route. The scenario two happens is when the guide wire does not go beyond the level of obstruction. It remains above the obstruction. And there you can just do a transmural stent placement between the GI wall and the bile duct. And depending on where you have entered, it's colodocoduodenostomy versus hepatogastrostomy, depending on your condition or your comfort, and so on and so forth. So let me show how they look like. This is a cartoon of colodocoduodenostomy. From the first part of duodenum, you puncture the bile duct, pass the guide wire up into the hilum, and then over that you do a cystotome, create a fistula, and then place a stent. So this is a patient who has a dilated bile duct with a mass in the lower end of the pancreas, in the lower end of the bile duct. So here the needle always looks at the hilum, guide wire goes in. It may sometimes bounce back from the hilum, but nevertheless, you can still continue the procedure. Create a fistula with a 6 French cystotome, a very important accessory. Before we started a talk, we had a discussion amongst ourselves, and this is one important accessory. If somebody is going into the domain of interventions, I think 6 French cystotome, which can go over a guide wire, is must. So once the fistula is created, the stent is passed. And mind you, we always use a fully covered stent for colodocoduodenostomy, 4 or 6 centimeters long. The idea of using a fully covered is there is no bile leak from the decompressing bile duct now into the paraduodenal space. Lumen opposing metal stents are a new kid, and they have also been used for colodocoduodenostomy, not the standard size, but the small caliber, 8 or 10 millimeter diameter of the axial stent can be used, both hot and cold. And it can be done as a freehand technique as well as over the guide wire. Both are safe in expert hands. Only the cost difference is more. When you use a tubular stent, the cost is less than half of what the current Axios is in India. It varies from country to country and the insurance schemes which can support it. But this is a very elegant way of draining the obstructed biliary system, because there is not long length of the tube hanging in the duodenum, and it doesn't cause any obstruction of the duodenum in case a patient has a pancreatic head cancer, because duodenal invasion can cause lumen compromise, and this stent does not help uh, cause any luminal compromise, unlike a tubular stent. Hepatical gastroscopy, another exciting method of drainage, as I said earlier, where you enter from a very proximal stomach, puncture and pass a guide wire, whichever direction it goes, to the right side or towards a common bile duct or across the papilla. You can place a stent with the inner end inside the left hepatic duct, or wherever you feel comfortable above the obstruction, and the luminal end in the stomach. Here in the cartoon, it looks like esophagus, but stomach is preferred. Let me show an example of this. This is a patient who had a hilar cholangiocarcinoma with only the right system blocked, and he had a metal stent placed in the right system about 4 months back. Then he came back with cholingitis. And now you can see that the left system is quite dilated. I would stop here for a minute and show the anatomy part again. So this is the left lobe of the liver. The duct which is going left of the screen is the segment 3 duct. This and this is a branch of segment 3. And the one which is going onto right of the screen towards the diaphragm somewhere here is segment 2 duct. And this is a very important anatomical differentiation which we should learn right in the beginning, because our aim is to drain the segment 3 duct, which is more inferior. And if you want to puncture this, your point of entry into the biliary tree will be in the proximal stomach. But if you want to enter the segment 2, then you have to come from this direction, and the point of entry can be esophagus, which we don't want if you're planning to use a hepatical gastroscopy. If you're doing rendezvous, that's a fine, but you never know your rendezvous is going to succeed or not. If rendezvous fails, at least you can do a hepatogastrostomy. And that's why it's always better to start from segment 3 and then do whatever you want if your guide wire has gone across the papilla and across the stricture. So you see this patient has a lot of thick sludge kind of a thing inside the bile duct. Here comes a needle which punctures the small segment. The contrast injection shows that it doesn't go across to the right side. The contrast says on the left side of the liver, we leave a guide wire inside. And then over this guide wire, keeping the guide wire always under view of EUS, we pass the 6 French cystotome, which comes now, burns its way in. And then you place a metal stent which is partially covered. So inner half is uncovered, and the other half, which is more than half actually, 30 to 70%. So this is a geobore stent with the inner 3 centimeters uncovered and the other 7 centimeters is fully covered. So this relieves this patient's cholingitis. And so if it is done well, it looks very elegant and you feel very happy. But if it goes wrong, then you feel very disappointed. And see the gush of pus coming out. And this was the final position of the hepatogastrostomy. Some of the stents have a special design of flare or fins which prevent the internal migration which can happen. If the stent does not have this capability, it is always better to keep a long length of the gastric end of the stent inside the gastric lumen. About more than 3 centimeters to up to 5 centimeters is what is preferred, because as the patient breathes over next few days or when he becomes awake, and deep breathing excursions will cause the stent to be sucked inside outside the stomach. So long length is always better. A few more examples of hepatogastrostomy. This is a patient who had a polypoidal hilar mass but duodenal obstruction. So he passed the guide wire across, lucky to go across the papilla into the duodenum, and this is how it look like. And then you can place either an antegrade stent all the way, or you can do a hepatogastrostomy. We did hepatogastrostomy here, because the intent in this patient was also to do a enteral stenting for the duodenal obstruction. Another scenario in a patient who is post-operative now with a distal gastrectomy for a cancer of stomach many months ago. He's now come with biliary obstruction, and ERCP shows a tight stitch in the lowermost part of the CBD. Our guide wire went in across, and we can actually now place an antegrade stent all the way. So this is a stent, a silver stent which has gone across. What about EUS interventions in benign diseases? Here's a patient who had stones in the bile duct but failed ERCP for various reasons. And we then did a EUS, passed the guide wire from the papilla into the duodenum, entering from the duodenal side. So this is a roundabout procedure. And once we caught the wire, this was an intraampullary diverticulum, and that's the reason. Intradiverticular papilla. Then we placed a plastic stent in the first go, and later on we did a few weeks later a complete ERCP. Another patient who had a stone in the and dilated bile duct system, failed ERCP. You see a transpapillary pancreatic stent is there, but the bile duct was failed to cannulate in spite of many attempts. So it was intrahepatic ducts was slightly dilated. So we punctured the left hepatic duct like we do in malignant biliary obstruction and managed to pass the guide wire across. You see a tight stone is blocking the lowermost part, which prevented our ERCP to succeed from the papillary side. Here we were lucky to pass the wire from top across the papilla, and we see not one but two stones there. And then finally the guide wire went across into the duodenum, and we did the stent placement again. So one need not do the complete procedure in the same go, because this patient already gone under so much of intervention. It's best to place a stent, come out and do the complete procedure a few weeks later when he's better. And with all these interventions, he did have a little perforation from the puncture site. And since we're using CO2, we're not so worried. The patient will have some pain because of bile leak, but this will automatically subside. And this we have learned actually more from our colleagues who are doing the third space endoscopy using CO2 when they do POEM and other procedures. They're not worried about air coming into the duodenum or the pleura. All the air or the CO2 gets absorbed with passage of time. So there's a new accessory which has come quite recently called rotatable needle. As the name suggests, you can see this, the needle tip can be rotated, and this would guide our guide wire to go in particular direction. For example, if you're puncturing from the duodenum into dilated bile duct system, the wire prefers to go towards the hilum, but if you want to go towards the papilla, this would help. As I will show in a case, this is a patient who had bile duct stones with recurrent mild cholingitis, and this was his papilla. You're not seeing any papilla. This is a diverticulum, but we cannot make which is the papillary opening. And attempts at several times to enter the bile duct failed. And this was a picture I showed in the beginning. The diverticulum is here. So we use this device, the rotatable needle, and see how it works. The bile duct with dilated stones, dilated with multiple stones. So as we withdraw the striate, needle curves little bit to 90 degree, and the other variety can go up to 135 degrees. So 90-degree bend needle we used. Withdraw the stylet, so the needle then bends, and you can then rotate towards the preferred direction. And then we injected contrast. You can see multiple stones in the bile duct. And finally, guide wire does come out of the papilla. And then we changed our scope to a regular ERCP scope, leaving the guide wire coming out of the papilla, and then complete the roundabout procedure. You see, it's still off. The papilla was so small and tiny in the upper lip, behind the upper lip of the diverticulum. So that's where it helps. Another area where EUS biliary procedures can help is a hepaticoduodenoscopy. This is a patient who had an anastomotic stricture between the bile duct and the duodenum after a complicated cholecystectomy. So the option was either second surgery or we tried to do some other way. EUS actually, PDBD failed in this patient, and that's why we used this device, a needle to pass from the duodenum into the intrahepatic ducts. And this is a small bridge to cross between the duodenum and the intrahepatic ducts. And we placed a fully covered stent after creating the fistula with a cystotome. This is a 4 centimeter fully covered stent. This is the left hepatic duct and the right hepatic duct. So we were worried that the stent may block the contralateral side, but it didn't happen. So this is the duodenal end of the stent being deployed. We pulled it as down as possible towards the anastomotic side so that the contralateral side was not getting blocked. And this worked quite well for this patient. And she did not have any cholingitis later on. And the stent was kept in for 3 months and then removed. Initially replaced with a plastic stent and then removed all of the plastic stent after further 3 months. And the patient is fine for last 6 months or so. So it can be used for benign indications also, EUS biliary drainage. So the overall advantage of EUS guide biliary drainage is that it has no external puncture and drain can be done in the same session of failed ERCP. Real time with Doppler helps us and can be done even in mild ascites. Obvious complications do happen, as we can see it here. This stent, which is a shorter stent compared to what we use 10 centimeter or longer. This was an 8 centimeter in the beginning of her career and it got sucked inside the peritoneum. You can see it here. He developed a little bit of ascites because of bile leak. Another complication which can happen is, you can see it here. This is again a similar patient who had a stent in the right side, gallbladder right side stent. He had a hilar block. So this is the left system now. Came with cholingitis. So get the cholangiogram. You see there's no contrast going to the right side, means it's a very tight block. And sorry. So we deployed the stent, a geobore stent was being used. And while placing under endoscopic view, he thought all this metal was the part of the stent, whereas actually it's part of his sheath. And this mismatch made us realize that we had lost the stent inside the peritoneum and the liver. And there's no stent in the stomach. But we were lucky enough to understand that the stent has got malpositioned, but the guide wire was still inside. And that was our lifeline. So we used this lifeline of guide wire and placed a second stent over the guide wire, telescoped inside the previous stent. So we were lucky to get bailed out of this crisis just because the guide wire is inside. So that's another important lesson for all the people who are doing interventions, is to never pull out the guide wire till you are 100% sure that the procedure is successful and complete. Use all the methods of visualization, fluoroscopy, EUS, and endoscopy. If you have colleagues next to you, take their help as well, because sometimes two minds are better than one, and you can always bail outside the crisis. So see, you can, one stent is inside, total here, and the second stent starts from here and goes all the way into the stomach. So we could rescue this internally migrated geobore. Coming to the gallbladder drainage, it's being done for patients who have advanced malignancies where the gallbladder is distended and infected. And percutaneous drainage, if you do, will have these tubes hanging for long, and these stents can be used either tubular or the lamps, and route can be duodenum or stomach. Duodenum is generally preferred because that's closer and causes less complications. A quick video of this. It's quite similar to the pseudocyst drainage. You puncture with a needle, pass the guide wire inside, coil it inside. You can pass some contrast, use again a cystotome, and then place the stent. So the steps are more or less the same, whereas this is a short tubular stent. Nowadays, most people are using lamps for gallbladder drainage and leaving that inside for long. Switching gears to liver now in the last segment of the talk. We see the liver very nicely, especially the left lobe from the stomach. And the right lobe also can be seen from the stomach, but mainly from the duodenum. Here you see this is a spleen It's a natural variation, and the liver is sitting on top of it. The left lobe of liver, let me freeze it here. This is a diaphragm. This is a spleen, and you can see that demarcation. The left lobe of the liver is sitting on top of the spleen. So it's a big liver, which is a normal variation. This is just to show that this can happen, and one should not get worried, because then you see the parenchyma here, and you can trace it back to the rest of the liver as well. In the right panel, you can see this is a tumor which is sitting in the caudate lobe area. Very difficult to FNA. This was a young lady who had come with incidental finding of this mass lesion, and we're not sure what we are dealing with. And we could do an FNAC from the lower esophagus. And you can see it here. I'm sorry, just a minute back. So this is the IVC, the hepatic veins, the left and the middle hepatic vein, and very close to the IVC. So the biopsy actually showed as paraganglioma. That's a different thing, and she underwent surgery to resect this tumor. But liver is quite good for the anatomy of portal vein, the hepatic veins, and the intrahepatic biliary radicals. We also see the secondaries inside the liver, and if you see such lesions, then you can also FNA them, because this gives the highest stage of the tumor or any malignancy. And if this is positive, you can always say it's a stage 4 disease. For a primary disease which looked resectable on other imaging, but EUS showed us these. Another example on the right side, you can see multiple liver metastases, very commonly seen by ultrasonographers who can do an FNA. But this is just to show that we can also do the same. Moving forward, this is hydrated in the liver, which can be quite common in India. I'm sure it's also in Pakistan as well. So this was a young pregnant lady who had come with obstructive jaundice and cholingitis. And we could not do CT. Ultrasound was not very forthcoming. So decision was to look for the stones in the bile duct, and we found something else actually. So we found this cystic lesion, and the bile duct also had a lot of things, and then we followed with an ERCP without fluoroscopy. So this was entry with a guide wire aspirating the bile to confirm, and then wide sphincterotomy, and you see these membranes coming out of the liver. So after cleaning up the bile duct without fluoroscopy, again I'm emphasizing, we placed a stent, and then after completion of pregnancy, patient underwent surgery for her liver hydrated. US guided liver biopsy is a new thing now, and we are also using it quite often now. The advantage where it scores over percutaneous or other methods of liver biopsy is that you can do biopsy from both the sides, both left and the right lobe. And we can also avoid portal vein and hepatic veins, which are major complications. Also, we are avoiding intercostal vessels if your percutaneous is a risk. So the major complications are now avoided. Only thing we have to be wary about, if somebody has significant ascites, this may not be the right way to go forward. The last segment, the last few slides on US guided portal pressure measurement, it's a new thing. We are still awaiting this device which can measure the portal pressures. Ken Chang and his group has published it quite elegantly, that you can puncture the hepatic veins and the IV and the portal vein, and through the needle this device gets attached. So you get a portal pressure measurement value, and then you puncture the hepatic veins, you get one value, and the difference of the two tells you the HVPG, which is more direct than the conventional HVPG that we are doing currently. So this would help us in measuring the hepatic venous gradient, and so on. We can also technically do a TIPS, which has been shown in animal experiments, but humans still vary because of risk of infections or transvascular interventions. Glue and coil can also be done. I'll skip it here for want of time and for discussions. So EUS is an excellent modality for ampullary, lower CBD in the gallbladder pathology. Hilar stricture is an equivocal use for diagnostic purpose, but FNA can be done if the disease looks to be locally advanced. For liver, diagnostic use is definitely there as an add-on to other armamentarium. And interventional EUS use for biliary tree is very, very exciting. And I'm sure all of you would be looking forward to use this method of draining the obstructed biliary systems in time to come. Thank you very much for your kind attention. These are our team and the bottom who have been instrumental in doing the number of procedures that we do at AIG. In last 12 years or so, the numbers were 5, 6, 7, 5 last year. This year, because of COVID, the graph would definitely come down, but nevertheless, we'll still be not very far away. And this is our team. I just want to show that it's a teamwork which really matters, and each one stands behind the other one to give us moral and physical and intellectual support. Thank you very much for your very kind attention.
Sandeep, thank you very much. Simply splendid. Excellent talk. I think even if you had been talking for an hour or so, people would have been listening to you with exactly the same attention. It's just so absorbing. You're such an excellent speaker, and the delivery of the content was so special that I'm sure that, like me, each and every one of us must have enjoyed it. There are a few questions, and there are lots of people who have joined us. Uh, the questions have come. One of the questions is that what what kind of needle do you said that you use a rotatable needle for directed needle, but and this 18.5 gauge needle. Do you use small needle as well?
So we use our regular needle use is 19 gauge Cook or Olympus or Boston Scientific needles are one way that we use commonly. But rotatable needle we use only for benign conditions like stone disease or something else where we want the job to be done completely. In malignant disease, if we fail to go across the papilla, at least we can do a transmural drainage. But for benign diseases, we don't want a stent to hang in there between the bile duct and the duodenum or the stomach, depending on where we have entered. And that's where I feel the rotatable needle is a way forward and should be available in centers who are trying to contemplate this kind of procedure.
Perfect. You see, EOS is more expensive as compared to PTBD. When exactly do you prefer using EOS as compared to PTBD when the ERCP has failed?
Okay. So I will take this question depending on the anatomy. Suppose a patient has a hilar stricture and it's probably type 4 or type 3 or beyond type 2. I would then request my intervention radiology colleagues to come into picture and take over from start itself. I will not try to do an ERCP and mess around. Uh, Unless I'm pushed to do it, and then I'm very, very careful by not using contrast and using only guide wire as my way to enter into the selective biliary system and then drain that segment which I intend to do. So I need to have a good roadmap is must for any biliary intervention, whether type 1 to type 4. And my preferred US interventions would be for type 1 and type 2. For type 3 and 4, I would use an ERCP route. For type 3, I would use an ERCP route, but in type 4, definitely I will take intervention radiology's help.
Good. There's a question from Dr. Meng Son. How to differentiate tangential image of normal papilla from small ampullary tumor?
Okay, so that's a very, very important question, Meng, that how to differentiate the tangential image. So you have to keep, if you're using a radial scope, then you view the same area in more than one position. So that means that if you're seeing from D1, D2 junction, you go down again into D2 and then come back. So same area you will be seeing back and forth by going across and coming back. Same example for linear as well. I would then station myself and torque myself from left to right so that I get from one edge to the other edge of the papilla with a lot of water in between. So I'm liberal in instilling water in the duodenum to look at smaller pathologies, say polyps or diverticulums or small stone or ampullary tumors. Uh, and that's where I sometimes use hyoscine, or we call it Buscopan here, to paralyze the duodenum so the water stays, that doesn't go away. Because anesthetists are sometimes vary that if you instill too much water, the risk of aspiration is here. So it's best that you put water. Other alternative is to insufflate a balloon with water and then interrogate it. But my personal preference, even if you have a balloon, instilling water gives a much, much better image.
The question from Dr. Arif Khan, that if you're suspecting any ampullary lesion or ampullary pathology, is it better to go for direct EUS rather than going for side viewing duodenoscope? What do you prefer? Although you have very clearly said in your presentation that it's best to evaluate ampulla with the EUS rather than going for ERCP straight on. But
Yeah.
Dr.
So,
Arif has
that's a very good question. I would re-emphasize that you use your duodenoscope first just to see. And if you have a doubtful lesion, you can take biopsy. But don't get inside the papilla. Don't be in a rapid mode to go inside the papilla and cut it off and put a stent. So duodenoscope first to see the papilla and the pathology. Go to EUS, do the EUS interrogation, and then if required, then you go to ERCP and do. So it means that the scope has to go twice duodenoscope, but so be it. You don't have to send it for cleaning because it can be just kept there, and you can finish your job in 5-10 minutes and then come back with the same scope and finish the job with ERCP. So assessment by EUS is first before ERCP, but duodenoscopic evaluation, yes, you should do. In fact, I would prefer to do that because visualization of papilla by an EUS scope is not as good as a duodenoscope. You would agree with me that.
Yeah, agreed. Perfect. Khalid, do you want to say
Uh,
something?
good morning from Orlando, Sandeep. How are you?
Hi, Mohammed. Good to see you.
How are you? Thank you so much for the excellent talk, and really appreciated it. And always good to hear you. Always good to listen to you. On the same line about this ampulla evaluation, one thing is just please keep in mind, especially when you're doing a ERCP, you suspect an ampullary lesion, and you think it could be treated with endoscopically, like ampulectomy or something, please do not do a sphincterotomy on that. Just put a smaller stent, because that makes it really, really difficult afterwards to do ampulectomy of that. And I totally agree. The best evaluation of ampulla or ampullary lesion is probably with the EUS. There's no other modality which can provide you a better imaging. So I have a question for you, Sandeep, with regard to benign disease of the bile duct, and if you fail a cannulation. Okay, let me retract. For the benign biliary disease, do you think the EUS would ever had a role as a primary modality, not the ERCP, primary modality to access the bile duct? And that's one thing, because some people do advocate or less risk of pancreatitis possibly, but at the same time, there are other complications which come with it. So what do you think, where does it stand in regard to treating a benign biliary disease with the EUS approach?
So currently, I feel ERCP is far superior than EUS for benign biliary disease. So let's dissect it further. Benign biliary disease means a stone disease, which is a commonest problem that we see. I think EUS will only come if ERCP is not possible or it's failed. Like I showed in some of the examples, uh, where diverticulum is preventing you to enter, or there's a stricture there or something else. Uh, but primary as a stone removal method, I don't foresee at this time that EUS will replace an ERCP. For the simple reason that once you remove the stone, how do you bridge that, or how do you seal off that leak, both from the duodenum as well as from the bile duct? And that is unless you leave a fully covered stent, which makes no sense, adding to the cost and the risk. Moving forward, I think for strictures, it may have some role there uh, as a as a stopgap measure. Um, Perez Miranda from Spain has done some of these work, and he thinks little laterally, as you know, that he has placed some of these fully covered stents in, say, intrahepatic or hilar benign strictures, and so has Takao Itoi from Japan, where they have used plastic stents. So you can place a plastic stent across these hilar strictures in a situations where ERCP is not possible. They've also done in where ERCP was not possible. And then you can keep exchanging their stone. There's stent, plastic stent, or with a metal stent, you have dilated the stent and then pull it out later. Or you can do a cholangioscopy through that stent and go inside and do a laser lithotripsy of the intrahepatic stones. Those things are technically and theoretically possible, but I think these are safe in super expert hands, and I would be hesitant myself to do.
Um, in that context, one of my senior colleagues, while I was doing training, he always taught me one thing, that if you're able to restore the normal anatomy, or if you can work through normal anatomy, it's always preferable. Stam Mustafa, thanks for joining.
Thank you. Thank you. Excellent talk.
Thank you.
Sandeep, we haven't met, but I'm familiar with your work. I'm in America as well. I had a question about choledochoduodenostomy. I've actually lost enthusiasm for it, partly because I've noticed that when patients live long, they seem to have a sump syndrome where they come back with obstruction, and then you're dealing with this. And occasionally I've even had patients go back and actually have percutaneous biliary drains because nothing we do seems to work. And I just wanted to hear from you your thoughts on that and your experience with that.
Excellent question. I think that's very important. So if people who live long, then the food matter can go inside these stents and can cause cholingitis, as was observed in Mohammed Yo's study, I think, from Florida. Uh, Also, the stent can migrate. So if the patient is likely to live long for any reason, I think then hepatic gastrostomy probably is better. Also, patients who have duodenal malignant disease, say pancreatic cancer, the periampullary cancer, or duodenal cancer, which is causing obstruction, my personal preference is to stay away from the tumor and do a hepatogastrostomy, because they will also require some kind of enteral stenting later on. And once you have a stent in the duodenum and you put an enteral stent, one will block the other. So you will have two problems rather than you solving one problem. Although we can tackle that by now USGJ, but that's a different ball game altogether. So staying away from the tumor zone is the theme currently which people are considering, so that whatever symptoms come up later can be tackled in the tumor zone.
Thank you. And then, if you don't mind, I'll ask another one. In terms of, I think you touched on this, benign disease and hepatical gastrostomy. The approach I've taken is fully covered metal stent, just like you said, across the stomach into the left lobe. And then I feel stuck. I mean, if you leave the metal stent, well, you run into problems. If you take out the stent, the opening may close down. And I'm just wondering, in your institution, is there a protocol that you have adopted for benign disease where you're doing hepatical gastrostomy, where you cannot access the downstream papilla, for instance?
Our main way of treating the patients with benign biliary strictures, say post-operative after complicated cholecystectomy, is percutaneous management and not EUS. EUS is only standby, or when we feel we want to show something. That's when we come in. But I think largely, I would say 90% plus is percutaneous management of these catheters, of these strictures by one or two catheters, and which are then upgraded at serial intervals 3 months apart for a total of 1 year, and then these catheters are pulled out. EUS as a primary modality of treating would not be correct, especially if it's a complicated stricture. If hilum has two strictures, you can only tackle the one from the left side. The right side we can't reach, and then we'll not be doing justice just because we can do something to the patient. So it is better to give it to the person who does the best job.
Yeah, no, in this one particular case, I have the people who can do the better job came to us. And so that's the challenge. Where do we go next? Because the patient's tired of the percutaneous drain. But those are one-off situations.
So there is one report also from the Korean group. Another super expert is there, Do Hyun Park from Korean Center, and they do a transduodenal route of drainage of. I reviewed one of his publications recently, and they have a series of patients where they're punctured from the duodenal cap, looking up into segment 6 or 7, and with the segmented duct, they placed a fully covered stent temporarily, which bailed them out. So that's an area which probably will, I think, more experience is needed from other centers of the world. That is this a way to go forward in such situations? So right side tackled from duodenum and the left side from the stomach in the same patient if they have two strictures at the hilum from benign etiology.
Okay. And I, by the way, I do both EUS and ERCP, and actually believe that ERCP has a major role to play in the future as well. There is some thought expressed often that EUS may replace ERCP. I have reservations, but I'd love to hear your thoughts on that, and then I'll stop asking. I'll give other people an opportunity.
No, I love ERCP as much as I love US, and I think ERCP does a much a better job than US. We still don't have the right, probably the perfect accessories for US. Once we have that, and the job is quickly done, where we can prevent pancreatitis, as Mohammed was mentioning earlier, I think then the competition would be stiff.
Pancreatitis has set in. So I think that's incredibly important. I'll just add one thing here, Sandeep. So obviously I don't think we can match your experience, but in terms of the choledochoduodenostomy, I think when you compare the LAMS versus the fully covered metal stents, so cases where the distal duct isn't significantly dilated, when I mean significantly dilated, that is if it's not more than 10 millimeter, then I think putting a LAMS carries a significant risk, whether you go with a freehand or a wire-guided technique. And I think in those cases, it's probably better to go with a fully the self-expandable metal stents than going for the LAMS. And as you've already mentioned about, there's a significant cost difference as well. But once again, thanks for a fantastic talk.
Thank you.
We're already 13 minutes about time. Do you want to say something?
No, I think thank you, Sandeep, for an excellent talk, excellent question answers, and I think we're already way beyond our time, so you can just no, it's not because of you, it's the question answers. We can go on for another hour because this is obviously exciting and this is interesting, but being a Sunday, I think it's not fair on Sandeep as well to keep him away from his family, so you can wrap it up. Excellent session. I think
some people still have to go to work on Sunday.
Thank you, Mustafa. Thank you, Nadeem, and thank you.
To do with one's age, my dear.
Thank you, everybody, for participating in this session, and I'm thankful to the Wilson Pharmaceutical as well for providing us with the platform. And thank you, Saad,